Good morning, students. Today we will be studying about the biomechanics of knee complex, taking into account all the structures which are supporting the knee joint to make it more stable as well as helping in mobility of the joint. Fine. In the previous video, we studied about the articular surfaces of tibiofibular joint, femoral joint, patellofemoral joint, the important angles, the Q angle, the medial tibiofemoral angle, and the importance of those angles. Fine. And then the patellofemoral joint and the importance of the movement of the patella when the knee flexion takes place. Now let us continue with the important accessory structures in the knee. The first thing is menisci. Now you understand that the convex, the distal surface of the femur is convex, and the tibial plateaus, they are flat surfaces. Now to improve the concavity of the flat surfaces so that it becomes a congruency is there, or that is the femur can move easily on the tibial surface, there is a fibrocartilaginous structure which is called as menisci. And these menisci in two in number, the medial menisci as well as the lateral menisci. As you understand this, the tibial plateau, as you understand this is the medial one, this is the lateral one. So you can see the medial, this is almost a flat structure. To give that concavity, there we require a meniscal surface. So the menisci is basically a medial menisci as well as medial and lateral menisci. Now if you can see from here, the surface is that this is the medial meniscus. The medial meniscus is almost a semi-lunar in shape, whereas the lateral meniscus is, you can see, it is almost covering 4/5 of the circle, and it has got two parts, the anterior part as well as the posterior part. Both this menisci has got anterior horn and posterior horn. The anterior horn and posterior horns are facing towards they are facing towards this intercondylar prominence or intertubercular prominence. Okay, they are facing towards it. That both the menisci are opening towards this prominence. Fine. And if you can see on the anterior surface, it has been supported by a transverse ligament. It has been supported by a transverse ligament. Fine. So these are the important structures. You can see again, I am telling this, the medial menisci you can see is a semi-lunar in shape. The lateral meniscus is 4/5 of a circle. It has got anterior and posterior horns, and which are opening towards this intertubercle prominence, and interiorly it has been supported by a transverse, interior horns are supported by a transverse ligament. Fine. And you can go through this yourself. Fine. Now the attachment, this is a very important part which I want to read from the slide itself. Now this is a menisci, and it has got round about 6 attachments with it. One is, it is attached with the deep fibers of the capsule. We will be studying the joint capsule in detail, but you should just remember this much, that it is attached, this menisci is attached to the deep synovial fibers of the capsule. The capsule is divided into superficial fibers and deep fibers. It is attached to the deep synovial fibers of the capsule. In the bony area, this is basically it is getting attached to the intercondylar fossa. That is, it is basically each horn, you can understand these horns, they are in this prominence, so they are being attached to the intercondylar fossa in the on the interior side. The patella, it is also attached with patella. You can see that the lateral edges of the patella, or the lateral border of the each meniscus is attached with the lateral edges of the patella. Along with the lateral edges, the lateral border of the meniscus are attached. And you also know that anteriorly it has been attached with the transverse ligament, and the muscular attachment is semimembranosus is fibers are being attached to the medial meniscus, and popliteus fibers are attached to the lateral meniscus. Fine, because it has been inserted here. So semimembranosus is getting attached, you can see from here, this is the surface. So you can see that there will be semimembranosus on the medial menisci, and the popliteus is attaching on the lateral meniscus, and the ligaments is, it has been also been attached by the medial collateral ligaments, is attaching with the medial meniscus as well as the anterior cruciate ligament. Medial meniscus is attached with the medial collateral ligament as well as the anterior cruciate ligament, whereas the lateral meniscus is attached with the posterior cruciate ligament. So these are the normal attachment which are important. Now you can see the surface over here, the diagram B. I want to show first see, this is the normal where the menisci is lying. This is the meniscus. Can you see? This is the structure of meniscus. In the second figure you see this is the peripheral part of the menisci and this is the central part of the menisci. The peripheral part of the menisci is really thick. The thickness of it can be seen over here. You can see it has got radial fibers, it has got circumferential bundles, it is vascularized, fully vascularized structure. So that means it is well thickened structure at the periphery, and at the center it is almost, it is really thin. So it is, the thickness is out and inside it is really thin. So this is the shape which is happening. In the center you can see it is not even covering the central portion. It is not even covering the central portion of the tibial condyle. Fine. So in the center there is no blood supply. So it is only through diffusion method, that is on weight bearing, diffusion of this diffusion method, only the deep fibers of the fibrous capsule, through diffusion it will give nutritious or vascular supply to the menisci. Fine. Now let us go through this. Now you understand the peripheral region is thickened and towards the center they are thin. Central portion totally depends on diffusion for blood supply. So once they are damaged, there is no self-healing. The peripheral area of the menisci, they have got nociceptors, that are pain receptors are there, mechanoreceptors. Mechanoreceptors are for the proprioception and joint position sense. Fine. So what does this menisci do? Menisci basically increase the corrugancy of joint. You understand, because the tibial plateau is flat, so it increases the concavity. So it is increasing the joint, the articular joint or articular stability of the knee joint. Fine. It is a shock absorber because it is taking the load. So it takes the load. Fine. And it also dissipates this load. It also dissipates the load, and this force which is coming over here, it acts as a cushion first, and then it's also dissipates the load. It dissipates the load so that there is less amount of the load which is passing, wear and tear is less at the knee, and it dissipates to the tibia. Fine. So it is responsible for the dissipation of the load itself. Fine. If I tell you this dissipation of load, I want to show you, like this is, if this is just a second. Now if you can see, if this is the condyle, fine, in this area, and if there is no meniscus is over here, so what is happening is the force which is coming over here is directly going like this. Can you see the directly going of force? Now if you see, this is a condyle and this is the surface, and there is a meniscus which is running here. Now the dissipation of forces will be like this. Now you understand the dissipation of force. Here it is acting directly, and therefore there is a role of this meniscus. Meniscus plays a very crucial role. We follow the formula over here, is that stress is equal to force upon area. Now it is more the surface area, less will be the stress. So stress is inversely proportional to area. Fine. If the area is more, that is the menisci is increasing the area for the force, so the kind of stress which is acting on the joint will be less. Fine. So this is how the dissipation of force is taking place. Fine. Now let us come. You can see over here the radial deviation of all the forces is done, because this is a wedge and here the dissipation of force is taking place. Fine. Now in early stages of life, meniscal is rich in blood supply, but after 50 years on weight bearing, there is decrease in blood supply. The blood supply is only in the periphery. The central rim is not getting, or the central area is not getting any blood supply. So if the person is immobilized, there will be no intermittent loading, on the knee joint, so no weight bearing and no blood supply to the central area, because in the central area there's only diffusion method, the blood supply takes place. So when damage to the peripheral region, reconstruction surgery is possible, but the surgeon will rarely go for a total meniscectomy. He will never go for total meniscectomy. Why so? Because you understand the load, the wear and tear of the joint will be more. If a small portion of it is also left, then the dissipation of load will be less, or the stress acting on the joint will be less. So we know that while walking it is 2 times of the body weight which is acting at knee, while running it is 3 to 4 times of our body weight which is acting or passing through knee, and while we are jumping it is 7 to 8 times of our body weight which is running or passing through the knee. So that is why they never go for a total meniscectomy. If they have to or remove it, sect it, they go for anterior horn or some fibers of the posterior horn, but they will rarely take full meniscectomy will happen. Now I hope you understood the role of menisci, the role of menisci in knee joint. Fine. Now let us come to the next important stabilizing structure, which is called as a joint capsule. Now the joint capsule is basically the joint capsule of knee is very loose and large. Fine. So that you understand it allows a movement at the knee. For the movement at the knee, it need to be loose and it need to be large. So fine, and it is divided into two. It has got two important type, if you can say, fibers. One is the superficial fibers, which is fibrous fibers, and one is deep, which is called as synovial fibers. Can you see over here also? It is synovial fibers and fibrous fibers. You can see the fibrous fibers, synovial fibers. The synovial fibers is containing synovial fluid with them. The synovial fibers is containing synovial fluid. Now let us go through. That is, capsule is large and loose and it covers all the articular surface. We will be going that in detail. Okay. And in medial and lateral compartment and the patellofemoral joint, the capsule has got 2 layers. The outer is superficial fibrous layer, which provides stability, and the deep synovial layer is holding the synovial fluid and the synovial membrane. Now this is the articulation. Now articulation, if we see that the joint capsule from anterior side, if you see this on the interior side, now when I say it anteriorly, you see the joint capsule is basically covering this quadriceps tendon. Interiorly, it is covering the quadriceps tendon, it is covering the patella, it is covering this patellar tendon. Anteriorly, the joint capsule is covering the quadriceps tendon, the patella, and the patellar ligament or the patellar tendon. And posteriorly, it is covering this condyles, this intercondylar area, the 2 condyles and the intercondylar fossa. It is covering this area. Fine. If you see posteriorly, it is covering this 2 condyles and the intercondylar fossa, as well as if I can show you like this, it is also covering the tibial plateau. It is also covering the tibial plateau. That is, posteriorly it is covering the condyles, the intercondylar, the fossa, as well as it is covering the posterior tibial plateau. Fine. It is covering the posterior tibial plateau. Fine. And yes, it is covering. And when we see this anteriorly it is covering the quadriceps, the patella itself, as well as the patellar tendon. Fine. And it is covering both the lateral and the medial condyles. From interiorly, or from the, if I can say, superior part, it is covering both the proximal condyles. Fine. So this is the attachment of the fibrous capsule. But on the medial and the lateral side also, they basically are been supported, or they cover the medial patellar retinaculum and lateral patellar retinaculum on the medial and the lateral side. So if I show you like this capsule, yes, it is lying like this. Now if I show you, no, it is better to show you like this only. Now if I show you this in this form, you see that it is basically covering if I show you this form, so interiorly the 2 condyles and the tibial, interiorly the quadriceps, the patella and the patellar tendon is been covered. Posteriorly the 2 condyles and the tibial plateau is been covered. Fine. Superiorly, you can see both the condyles and the intercondylar notch is been covered, and here the tibial plateau and the prominence, the tibial prominence has been covered. Now the important part is the medial and the lateral side. On the medial side, we have got a medial retinaculum, medial patellar retinaculum and lateral patellar retinaculum. It has also been enclosed by the joint capsule. Now this retinaculum is basically a part of extensor retinaculum of knee. It is also known as the extensor retinaculum of knee. Now extensor retinaculum of knee is basically a fascia. It is a fascia. If I can show you a picture over here. Okay, let me go through the slide. Anteriorly, from the inferior aspect of the femur to the superior aspect of the tibia, the attachment, and the posteriorly to the posterior margin of the femoral condyle to the intercondylar area of the tibial condyles. Medially, it has been, and laterally it is enforced by the capsular ligament. These capsular ligaments are part of retinaculum. The part of retinaculum. Fine, we will be talking this in detail in the next slides. Fine, so the function of this joint capsule is: one, it holds the synovial fluid. Second, it gives the proprioceptors, nociceptors and mechanoceptors are there. So it gives you that pain sensation or joint position sense. And of course, this joint capsule is stretched when there is an extension. So it gives a passive kind of a stability to the joint. Fine. I was talking about this retinaculum because the medial retinaculum and lateral retinaculum plays a very important role, a crucial role. Now retinaculum is basically a fascia which is present on the interior surface of the knee. Now it basically covers this interior surface or the interior fascia. It covers this quadriceps tendon. It covers this quadriceps tendon, the patella, the patellar tendon and the tibial tuberosity. So this is the area. This is on the interior side. The fascia is basically covering the quadriceps tendon, the patella, the patellar ligament and the going up to, or the patellar tendon up till the tibial tuberosity. It is covered like this. On the extensor retinaculum, on the medial side, it has been supported by the medial patellar retinaculum, and the lateral side it has been supported by the lateral patellar retinaculum. Fine. So these are the structures which are there. This is quadriceps muscle, quadriceps on the lateral view. I am just showing you the lateral view of extensor mechanism. Quadriceps muscle, quadriceps tendon, patella and patellar tendon. Fine. So it has got medial patellar retinaculum and the lateral patellar retinaculum. Now try to understand what are these retinaculum. Basically these retinaculum is the capsular ligaments which are arising, which are within the capsule. Capsular ligaments means all those ligaments in the capsule. There are 8 ligaments which are there inside the capsule. So it is very important when there is any kind of a surgery is there, we write it is intracapsular or extrasynovial, intracapsular or extracapsular. We write this terminology so that it comes into picture whether it is inside the capsule or outside the capsule. Fine. So it tells you the depth at which the ligament is there. So there are intracapsular or capsular ligament are 8 in number. There are 3 on the medial side, 3 on the lateral side and 2 on the posterior side. Fine. The 3 on the medial side are basically, let me show you in this form so that you remember by this. Okay. We are talking about, okay, let me show you like this. Okay, we are talking about the medial side. Now the medial side has got medial patellar retinaculum. Now it has got 3 important ligament. One ligament is medial patella femoral ligament, then medial menisci patella ligament, third medial tibial patella ligament. So it has got 3 attachment. This is for the patella. You understand, this is patella, so that is why it's called as patellar retinaculum, medial patellar retinaculum. So all the fibers of the patella are attached to the medial condyle of the femur, to the medial menisci and to the medial tibial condyle. So the 3 ligaments are these, that is medial patellofemoral ligament, medial patellomenisci ligament, medial patello, there will be tibial ligament, tibial condyle ligament. Fine. So these are the three ligaments which are forming on the medial side. So these are three capsular ligament. Along with this ligament, there is attachment of vastilis muscle, that is vastilis medialis muscle on the medial side, because since it is attached at the adductor tubercle, and this is the adductor tubercle where it is attached. So it has been supported by the muscle is also getting medial retinaculum is being supported by a muscle which is called as the vastus medialis muscle. On the let's come on the lateral retinacular side. It has also got three capsular ligaments on the same line. This is the patellofemoral, lateral patellofemoral ligament, lateral patellomeniscal ligament, lateral patellotibial ligament. So these are the three ligaments which are supporting the lateral patellar retinaculum. Along with this, there is a muscle which is attached, which is the IT band, which has been attached, which helps to give the stability to the medial and the lateral patellar retinaculum. Other than this, there are two other capsular ligament which is on the posterior side. Fine. The posterior side, it has been supported by two ligaments. It is arcuate ligament which is on the posterolateral side. The posterolateral side is supported, let me show you in this form, the posterior side. This is the lateral side now. The posterolateral side is supported by the arcuate ligament, and posteromedial side is supported by the oblique ligament of oblique popliteal ligament. Oblique popliteus is almost like an oblique muscle, and you can see the oblique popliteal ligament is supporting the posteromedial side. So that means there are 8 ligaments, capsular ligaments, which are forming, which are been supported by the capsule and the extensor retinaculum, and it becomes a part of extensor retinaculum. Can you see over here? I wanted to show you. This is again the muscles. You can see the quadriceps muscle which has been supported by, you can see the rectus femoris, the vastus medialis, the vastus lateralis and the rectus femoris, which are joining together at the patella to form a patellar tendon. Fine. At the level of tibial tuberosity. This is the anterior structures. Then you see this is the lateral retinaculum which has been supported by IT band, and this is the medial retinaculum. Can you see? This is the medial retinaculum which has been supported by the vastus medialis muscle. This has been supported by vastus medialis muscle. The medial retinaculum is supported by the vastus medialis muscle. This is how the attachment takes place. Now coming, this is fibrous side of the capsule. The fibrous side of the capsule, we saw this, that it is attached to, is attached to 8 capsular ligament, as well as you have seen the attachment on the anterior, posterior, inferior and superior side. Now there is a deep part to the capsule also. Now the deep fibers of these capsules basically hold the synovial fluid, and this synovial fluid is responsible for giving nutrition to the articular cartilage as well as to the menisci. Fine. So this deep layer is attached anteriorly to the interior cruciate and posterior cruciate ligament. Now you understand this interior and posterior cruciate, we write it like this as intracapsular but extra synovial. It is outside the synovium. Fine. So that is why I say anteriorly it has been supported by, or it is associated with interior and posterior cruciate ligament, whereas posteriorly it fuses or it breaks with or it joins the fibrous capsule. On the lateral side, it has been supported by the popliteus muscle and the lateral femoral condyle. It is attached to the lateral femoral condyle and the popliteus muscle. And on the medial side, it has been supported by the semimembranosus and the medial femoral condyle. Fine. So this is very much important. So how it has been attached? Why a popliteal on the medial, on the lateral side? Because I wanted to show you this figure. Popliteus is this oblique muscle. Can you see? This is an oblique muscle. Fine. This is an oblique muscle. So now you understand this is the lateral side. It is on the lateral side. It is getting attached. Fine. So you can see this. Now coming to the next point is, and this is a very important point. when in embryonic stage, the medial and lateral tibial femoral condyle has got separate joint capsule and their separate synovial membrane, synovial fluid also, and membranes. But after birth, till 2 to 3 years, the capsule fuses together and the synovial fluid also comes together. Now sometimes the remnants remain, the small remnants, they remain. So that becomes a problem area, that is called as plica syndrome. That becomes a loose folds are kept here and there, the remnants are left here, loose bodies are left here and there. That becomes painful, cause of a painful knee, and we categorize it as a pica syndrome. Fine. I hope you have understood the joint capsule itself. Now we started joint capsules in this form. It has got 2 layers. Now the superficial fibrous layer and the deep synovial layer. There here in this slide we have done the attachment of the joint capsule. And in this we have also seen the role of capsular ligament, the medial and the lateral side, the role of capsular ligament. Now this is the function of holding synovial fluid, passive stability, and the proprioception and sensory feedback. So extensor retinaculum was important because of the medial patellar retinaculum and lateral patellar retinaculum, which is a part of extensor retinaculum. Therefore I made you go through these slides. What is extensor? It is basically a fascia which is covering these structures on the anterior side and medial and lateral side. Fine. The parts of the medial, lateral, patellar, retinaculum, and the 8 capsular ligaments in it. Fine. So these are a part of the superficial fibrous capsule, joint capsule. And this then we talked about the deep layer of the synovial, layer of joint capsule, which is the synovial layer also, and how it is attached to the anterior cruciate ligament anteriorly. Posteriorly it is joining with the fibrous capsule, laterally with the popliteus muscle and the lateral femoral condyle, and medially to the medial femoral condyle and the semimembranosus muscle. Fine. Now let's start with another, we have done with the menisci, we have done with the capsules. Now let us go in for the medial collateral ligament. Now medial collateral ligament is also called as the tibial collateral ligament, and it arises from the femoral condyle to the tibial plateau, okay, just below the adductor tubercle. Now looking at this again, if we see this again, fine, let me show you on this side. So it is basically getting from the medial femoral condyle, this medial collateral, because it is on the medial collateral side. So it rising from the medial collateral, medial femoral condyle, and it is going up to the adductor. This is the adductor tubercle. So it is going up to the adductor tubercle, and it is also going to the shaft. Adductor tubercle, and it is, let me show it like this, it is forming like this structure. So it is going from this and going up till the shaft. Fine. So it has got 2 fibers, the superficial fibers and the deep fibers. So anteriorly it has been supported, anterior fibers are superficial and long fibers, and deep are posterior fibers. The anterior fibers are 10 centimeter long and 1.25 centimeter wide, and it originates from the medial condyle and inserts into the shaft of the tibia. It inserts into, because it is long, so it is originating from the condyle and going up to the shaft till there is an insertion just to the pes ansaris, where there is an insertion of semitendinosus gracilis and sartorius muscle. Whereas deep muscle is little bit posteriorly oriented, and it is from the medial condyle and goes to the proximal tibia, where there is insertion of semimembranosus muscle is there. Fine. You can see it from here. This is the medial collateral ligament. So here it is arising from the medial condyle and going up to, you can see the adductor tubercle, and then going up till the shaft also. It is going down till the shaft. Fine. This is the superficial, you can see over here the superficial fiber and the deep fiber. You can see the superficial fibers are long and going up to the shaft, whereas the deep fibers are short and they are posterior fibers, and they are going and inserting along with the semimembranosus tendon. Fine. Now what is the function of medial collateral ligament? Medial collateral ligament is very strong ligament, and it can resist up to 4,000 Newton force. Fine. So, and therefore it is a common, very common muscle which has been injured, very common ligament which has been injured. Fine, because you understand on the medial side, so it resists all the valgus stresses. It is on the medial side, so it resists all the, on the medial side, so it will resist all the valgus stresses. So it will hold on the joint when there is a valgus stresses are acting on it. Fine. So it also resists the interior tibial translation. Now what is happening is interior movement of the head of the tibia, translation of the tibial translation, that is when the head moves anteriorly. You understand this, and since it is holding, everything is holding here, it is holding here, so it will not allow the head to move anteriorly. So it is, since it is inserted here, so it prevents the interior movement or interior translation of tibia. Fine. So it prevents this, and it also prevents the lateral rotation of tibia. It also prevents the lateral rotation of tibia. So that means the role is, it holds the valgus stresses, it holds the interior tibial movement, and it holds the tibial rotational movement also. It prevents the tibial rotational movements also. Fine. So in what is important is the maximum resistance. When does it provide? In knee extension, it gives, it is taught. So it provides or prevents the rotational movement. It provides prevents the valgus stresses acting up to 50%. Whereas when the knee is bent to 20 to 30% degree, then the MCL is acting 80%. That is, it is holding or resisting the valgus and stress up till 80%. So that means its maximum function is when the knee is flexed 20 to 30 degree. Whereas it is also doing resistance to valgus stress when the knee is extended, but it is only up till 60%. Now the lateral collateral ligament, as the name suggests, the medial one was arising from the tibia, so it is tibial collateral ligament. So it is arising from the fibula, it is fibrocollateral ligament, but this is extracapsular. Remember, in the attachment of the in the attachment of the menisci, I have written and I have shown you the role of MCL. I have not told you about the role of LCL. So you remember, this is an extracapsular. It is an extracapsular ligament. It's a fibrocollateral because fibula is not taking part in the knee. So you remember, so that is why it's a fibrocollateral ligament. It rises from the lateral femoral condyle to the fibral head, where there's along with the biceps femoris tendon. It resists the varus forces, and it also resists the lateral tibial rotation, that is the medial rotation. So that is medial rotation of the tibia is holded and controlled, and the posterior translation of the tibia is also been checked by the lateral collateral ligament. So how it is injured? It is injured during high impact twisting movement, and we hardly go for any surgery because it is self-healing, and as it is well vascularized. So we basically go in for a RICE management, rest, ice, crepe bandage and elevation management for this. Now the next ligament which I want to discuss with you guys is the anterior cruciate ligament. Now the anterior cruciate ligament is again arising from the lateral femoral condyle, and posteromedially it is arising, and it getting inserted at the tibial plateau at the medial tibial intercondylar tubercle. Let me show you the figure first, then you will be able to understand. This is the, can you see, this is the anterior cruciate ligament, and this is the posterior cruciate ligament. Can you see? These are the two views I wanted to show you, the side view and the posterior view. Now here you can understand it is getting yes, now here you can understand where it is getting it posterior medial aspect. It is arising from the posterior medial aspect of the lateral femoral condyle. From the lateral femoral condyle, posteromedial aspect, it is getting arised, and then it is going anteriorly, medially to the tibial intercondylar surface, that is intertubercle. In this area anteriorly it is running. The direction of the fibers, if I can tell you properly, is it is on the inferior surface. So inferior, and it is inferior, anterior and medial direction. The direction of anterior cruciate ligament fibers are, that is, it is inferior, and it is anteriorly running, and it is running on the medial side. So that is, it is arising something like this. Okay, you can see it is arising from the, you can see it is arising from the medial surface. It is arising from the condyle, yes, it is arising, but it is arising from the posteromedial surface. Fine, not on the lateral surface. So let us read through again. It is arising from the, now you can see it is arising from the posteromedial. It is here. This is the surface. I don't have a pen now. This is the surface it is arising. It is arising from posteromedial surface. Okay? It is arising from the it is arising from the posteromedial surface, and it is going up to the tibia, and it is going up to the tibia here in the posteromedial surface, and it is going up to this area. This area is medially and anteriorly. From the posteromedial surface, it is arising. Let me show like this way. It is easy for you to see. Now this is the lateral side from the posteromedial surface, and it is going and coming in front, and anteromedially it is showing in front. It is arising from the posteromedial side and going in front, that is inferior, medial, anterior. The orientation is like this. It has got two bundles, what is called as the anterior medial bundle and the posterior lateral bundle. Now you can see this, it arising inferior, anterior, medially. So it has got anterior medial bundle and posterior lateral bundles. It has got two important bundles. Now if this is running like this, so it restricts the interior or a translation of the tibia and femur. So this is anterior medial bundle is active in knee flexion, whereas posterior lateral bundle is active in knee extension. If we can say, anterior cruciate ligament is active throughout the knee range of motion, and it prevents hyperextension also. It also provides stability in rotational movement. Fine. That is, it provides more stability in the medial rotational stability in knee extension. I can show you in this diagram. Now you can see in extension, this is the red diagram. The posterolateral bundle is taut, whereas the anterior medial bundle is slacked in extension. Fine. What happens in flexion is, during flexion the anterior medial bundle is taut, whereas the posterior lateral bundle is slacked. So this is how the movement is taking place, which is written over here. Fine. You can see. Let me read this through. The anterior cruciate ligament, it restricts the interior translation of the tibia, because you understand it is running, so it will not allow the tibia to move anterior or posterior. So it is basically restricting the anterior movement, because it is arising from the posterolateral oblique nature. It is oblique in nature, so it will not allow tibia to move further, because it will be taut in this position. So it will interior translation has been halted by the anterior cruciate ligament, and it has got two bundles, anterior medial bundle, which this is basically active in any of the flexion movement. The anterior cruciate bundle, and both the bundles are active in any of the knee range of motion. But if we see specifically, the anterior medial bundle is active in knee flexion, and posterior lateral bundle in knee extension. So it also prevents the hyperextension of knee. So it also prevents the medial rotation. Medial rotation is that is rotational stability has been given, which is controlled by the posterolateral bundle. It controls the valgus stress along with the medial collateral ligament, and it controls, during the knee extension, controls the medial rotation. Fine. There are muscles also which around the knee, which can impact the anterior cruciate ligament. Like quadriceps muscle is basically a knee extensor. It brings about, quadriceps muscle is a knee extensor. So that is, it extends the knee. Now when there is an extension, if it is bent, there is an extension, this is bending, and this is extension of the knee. This is bending of the knee. And when we come into extension, you see that there is an knee, their tibia is moving anteriorly. Remember guys, we are talking about the movement of tibia. Herein concave surface is moving on a convex surface, and the osteo and the arthrokinematics is on the same side. So that's why I'm saying that when the tibia is moving in is a knee extender, so we basically see is fine. So this is the movement which is happening over here. Now in knee bending, what happens is it is capable, quadriceps brings about, this is from the knee bending, This is the knee bending position, and the tibia is moving anteriorly. When the tibia is moving anteriorly, it is producing anterior roll and glide. So interior gliding movement or interior translation movement, it causes a stress on the interior movement, brings about a stress on the interior cruciate ligament. You understand why? Because its anterior medial bundle is totally taut in that position. Fine. So it will not allow any interior translation of tibia. Whereas ham's muscle is knee bending, causes knee bending, and it causes posterior translation of tibia. It relieves the interior cruciate ligament. So it is a reliever, and it stresses the interior cruciate ligament. Similarly, for gastrocsoleus, brings about plantar flexion. It brings about plantar flexion, but it also brings about interior translation of the tibia. So it stresses the interior cruciate ligament. Whereas soleus muscle brings about posterior translation of the tibia, and it relieves the interior cruciate ligament. So when there is co-contraction of the muscle is taking place, that is when quads and hams are working together. So interior posterior translation of the tibia is reciprocally inhibited. Fine. Now if we see that the posterior cruciate ligament, now it arises from the medial femoral condyle, and its fibers are anterolaterally. It arises from the medial tibial, it arises from the medial femoral condyle from the anterolateral part. That is, if I see the anterolateral part, it is arising, and it goes up to the posterior horn of the both menisci. The posterior horn of the both menisci was here. Okay, so it is something like this, something from here, and it is going up till here. So it is almost like a vertical orientation is there. The inferior posterior fibers, its orientation is, it is almost straight, posteriorly running and inferiorly running fibers, because it is arising from the medial femoral lateral side of the medial femoral condyle lateral side, anterolateral side, and it is running to the where the posterior horns of the both the menisci are there. It goes and inserts over there. So its direction is inferior posteriorly, and it is much shorter. The ACL was oblique, whereas PCL is much shorter, but its cross-sectional area is very large, so it is much stronger. It is 150 times the cross-sectional area of ACL. It is much stronger. Fine. So it has also got two bundles. One is the anterolateral bundle, and it is opposite to that of the ACL. It has got anterolateral bundle, and it has got posteromedial bundle. Fine. So the posteromedial bundle is active in knee extension, whereas the PCL is you can see in flexion, in 80 to 90 degree of knee flexion, the anterolateral bundle is active. So it can be seen that the role is that only in 80 to 90 degree of knee flexion, the anterolateral bundle will be active, and lest a posteromedial bundle is active in knee extension. I wanted to show you it in a diagram, if it is possible. I've missed one diagram here. No. I have missed one diagram. I'll to show how they are being taught. Maybe in the osteokinematics and the arthrokinematics I have added those diagrams. Okay, but you try to understand this, that the anterolateral bundle and posterior medial bundles are there. The posterior medial bundle is working or is active in knee extension, whereas anterior lateral bundle is active when the knee is bent from 80 to 90 degree. Now the function is, you understand, posterior translation of the tibia is been restrained by the posterior cruciate ligament, and it provides the tibial rotational stability. The lateral rotation, the ACL was giving medial rotational stability, whereas this is giving a lateral rotation stability. Now role of the muscles, now it is opposite. There the hams knee flexors was bringing about the posterior translation of the tibia, which is giving a stress on the posterior cruciate ligament, whereas the quads, which was producing interior translation of the tibia, is reducing the load of the PCL. So the role reversal is there. All the muscles which were causing stress in ACL is basically is not giving stress, it is relieving the PCL. So it is reciprocal kind of a movement is there. But popliteus works as PCL. This means that if the PCL is posterior cruciate ligament is not present in a person, the popliteus will take its action because of its oblique nature. Fine. In the next video we will be going through the kinetics and the kinematics of knee joint. In this video we have covered the menisci, the joint capsule, and collateral, and the cruciate ligament. These are all the structures which are around the extensor retinaculum. These are all structures around the knee which are supporting the knee or which are stabilizing the knee during the mobility. Now in the next video we will be talking about the mobility of the knee. Till the second video was only on the stability, all the factors responsible for the stability of the knee. Fine. I hope you have understood this lecture, and if you have any doubts, please post in your comments in the comment section. Thank you.